Good evening. Today we shall be dealing with the assessment of reperfusion post thrombolysis or primary PCI. Now, this is a very important topic, and we should especially be concentrating on the post thrombolysis patient. However, the same features are also applicable to the post primary patient. So, if you like these videos, please like, share, and subscribe, and press the bell icon to get notified when a new video uploads. So, let's get a bit technical. You should know what is TIMI flow. TIMI zero flow is when you have a complete occlusion of an artery with no flow distal to it. TIMI 1 is when you have a slight penetration of contrast distal to the occlusion. TIMI 2 is when the artery fills slowly but completely. And TIMI 3 is when the artery fills normally and with normal flow. So your aim in primary PCI or thrombolysis is to get from TIMI 0 to TIMI 3 flow. Here you can see the mortality difference. When the patient has TIMI 0 or TIMI 1 flow, the mortality is 9.3%. Whereas if you're able to achieve a TIMI 3 flow, the mortality drops by 2.5 times to around 3.7%. So get from TIMI 0 to TIMI 3 flow. Now, how do you assess the success of thrombolysis? This is especially important if when you're considering whether to take up the patient for a rescue PCI or for further assessment. So there are various clinical markers, ECG markers, as well as enzyme markers. The first is prompt resolution of pain. So this should be the most important. Now, the patient is having great difficulty due to the presence of chest pain. You have to ensure that the patient's pain gets relieved. And the fastest way to do so is to give a thrombolytic agent or do a primary PCI and re-establish blood flow. The pain should be promptly resolved on institution of lytic agent or primary PCI. The sudden decrease of pain may indicate coronary reperfusion. The pain should suddenly as well as significantly decrease. Even a dead myocardium will have no pain. So if a patient has severe pain and you have not done anything, after around 10 to 12 hours, the pain will automatically subside because the myocardium is dead. So a dead myocardium, there's no pain. So in previous times, before the advent of thrombolysis or primary PCI, they used to give the patient heavy doses of morphine, around 10 to 15 milligrams of morphine. The patient would sleep for 2 to 3 days, and when he wakes up, he'll have no pain, but LV dysfunction would be there. So the sudden decrease of pain may indicate coronary reperfusion. A mild lingering pain may be normal. The patient may have around 5 to 10% residual pain, which will take around 24 hours to resolve. So there should be prompt as well as significant decrease in pain while giving a thrombolytic agent or post-primary PCI. There are certain problems with taking pain alone as a reperfusion markers. You have MIs which can present without pain, like with dyspnea or fatigue. In those cases, you cannot rely on this resolution of pain. Pain perception is subjective. Some people have a higher threshold of pain and they may not consider their pain to be significant, while some people may have a lower threshold and may scream with pain even with mild painful stimuli. Finally, you might have given the patient morphine, fentanyl, or midazolam, certain analgesics, which will also make it difficult to assess pain. And most important is pericarditis pain. So let's say I've lysed the patient and then patient 3 days later has chest pain, and you take an ECG and find that the ST has re-elevated. You might think it's a reocclusion. However, on careful examination, you'll find that the pain is different from his previous MI pain. It is pricking in type, occurs on deep inspiration or coughing, occurs when the patient is sitting, radius to the trapezius ridge, and you might get a pericardial rub. And the ST elevation might be present in all leads. So this is pericarditis. And this should be differentiated from your earlier anginal pain because you might mistake it for a reinfarction. So prompt resolution of pain, the first marker. 2 is achievement of electrical and hemodynamic stability in a patient who was previously electrical and hemodynamically unstable. Let's say you have a patient who is in cardiogenic shock and you have opened up the artery by using primary PCI. The BP picks up immediately. You can say that this is a marker for reperfusion. Or in another case where the patient is having a recurrent VTVF and you have opened up the artery and you find that the VTVF settles. This is also a marker for reperfusion. So achievement of electrical and hemodynamic stability in a patient who was previously electrically or hemodynamically unstable is also a marker for reperfusion. Now, word regarding hemodynamic instability, large area of myocardium should be at risk for a patient to become hemodynamically unstable. It's not going to occur when a small OM or an RPDA is involved. It should be a large artery, like a proximal LAD or left main should be involved. The patient should have either an RVMI or mechanical complications like free wall rupture can also cause hemodynamic instability. So hemodynamic instability, you need a large area of myocardium at risk, RVMI or presence of mechanical complications. However, electrical instability is not dependent on the size of your occluded vessel. You may have a small right posterior descending artery may be occluded and the patient may have recurrent VTVF, whereas a proximal LAD might be totally electrically stable. So electrical instability is not dependent on the size of the occluding vessel, and it generally occurs early in the course of MI. So if you work in hospitals where the patient presents after 6 hours of MI usually, or there's a large total ischemic period, you might not find VT or VF occurring in those patients because by 6 hours, most of the patients are already filtered off. Either they are dead or they've gone to some other hospital. So electrical instability is independent of the size of the occluding vessel and occurs early in the course of MI, usually within 6 hours. Third is ST resolution. This is the most important finding and the most validated finding we have, which has been extensively studied. So let's take this. You have a patient who's presenting to you 9 hours after chest pain. Will you thrombolyze this patient? He has ongoing angina. You can see that the patient has an anterior wall MI. He has QS complexes in V1 to V4, a tiny wiggle of an RA in V5, V6 with ST elevation. Now, most people will definitely thrombolyze this. This is actually the right answer. You're supposed to thrombolyze this patient if you don't have a primary PCI facility. However, I've seen certain people not thrombolizing this, saying that the MI has already evolved. The ECG has gone for QS complexes. There's no benefit for thrombolysis. Remember, the patient is having chest pain. Presence of chest pain signifies viable myocardium. There is ST elevation on the ECG, and the patient is within the window period within 12 hours. You might not get as much benefit as thrombolizing early, but however, you will get benefit. This patient requires thrombolysis. Remember, the presence of Q waves is not a contraindication for thrombolysis. Q waves are often seen as early as 1 hour after pain onset, especially in anterior wall MIs. So remember, just because you see a Q wave does not mean that the patient is not a candidate for thrombolysis. You can still thrombolyze this patient. So keep that in mind. So is ST resolution important? This is a compendium of 4 studies. Complete ST resolution was defined as ST resolution of more than 70%. Partial was defined as ST resolution between 30 to 70%. And none was ST resolution less than 30%. You can see when the ST resolution is more than 70%, you can see a very low mortality, around 2.5 to 3%. Whereas when there is poor ST resolution, that is less than 30%, you can see the mortality is close to around 15%. So there is around a 4 to 5 times mortality decrease when there is good ST resolution of more than 70%. So you aim to achieve an ST resolution of more than 70%. Again, this is a bit of a complex chart. However, I shall try to make it as simple as possible. They compared ST resolution on the ECG and they did an angiogram and found out what the flow was. When the patient had a ST resolution of more than 70%, they found that 80% of the people had TIMI3 flow. So a ST resolution of more than 70% indicates TIMI3 flow. However, the point I want you to know is this. A poor ST resolution of less than 30%, still 44% of the people had TIMI3 flow. So if you have good ST resolution more than 70%, most of the time you have TIMI3 flow. However, the absence of it does not mean the patient does not have TIMI3 flow. So some questions. How do you calculate ST resolution? When do you take your post-lysis ECG? What percent ST resolution constitutes a successful lysis? And lastly, what is failed lysis? There's an anterior wall limit has been successfully thrombolyzed. You can see there's a very good ST resolution here. How do you calculate ST resolution? The most common method is you take a sum of all ST elevations. That is, in this case, you take ST elevation in count the number of squares it is elevated in 1 AVL V1 to V6, you get a value. You take your post-lysis ECG, you get another value, and you find out the percentage ST resolution. So let's say pre-lysis, your sum of all ST segments is 20, and post-lysis, it becomes 10. You have a 50% ST resolution. Another validated method is a single lead maximal ST elevation. That is, in this case, V4 shows the maximum ST elevation. You look at V4. Let's say there's a 12 millimeter ST elevation. You lyse the patient, look at V4 again. Let's say it's a 6 millimeter ST elevation. Now you say it's a 50% ST resolution. This is also validated. However, sum of all ST elevations is what is most commonly used. The important point is ST resolution of more than 70% signifies TIMI3 and MPG3 flow. TIMI3 is epicardial coronary artery flow. MPG3 is myocardial perfusion grade 3, which signifies microvascular flow. So if you're able to get an ST resolution of 70%, it signifies good epicardial as well as microvascular flow. So this came in the American Heart Journal 2004. Single lead ST segment recovery is validated as a simple and reliable marker for successful fibrinolysis. When do you take a post-lysis ECG? 60 minutes, 90 minutes, 120 minutes, 180 minutes? Why bother? The correct answer is 90 minutes because all of your studies, or most of your studies rather, use 90 minutes as your cutoff. However, some studies have actually used 60 minutes. However, the worldwide standard is 90 minutes after the thrombolysis has been completed. So you give streptokinase, you wait for 1.5 hours, take the ECG. You give a tenecteplase, you wait for 1.5 hours and then take the ECG. This is to establish standards. ST resolution of more than 70% indicates a successful thrombolysis. Less than 50% indicates a failed thrombolysis. You plan to take the patient for a rescue PCI. Between 50 to 70% is acceptable. Next is, which thrombolytic agent would you prefer? So this is an anterior wall MI. So which thrombolytic agent would you prefer, assuming you are not working in a primary PCI setup? The correct answer is you prefer newer thrombolytic agents like tenecteplase, reteplase, or alteplase in preference to streptokinase. Remember, the newer thrombolytic agents cost at least 7 to 10 times more than streptokinase. However, they have a higher patency rate. You look at the patency rate is between 80 to 85% in compared to streptokinase. When you give streptokinase, 1/3 achieve more than 70% ST resolution. 1/3 achieve an ST resolution of between 50 to 70%, and 1/3 achieve ST resolution less than 50. That is, they have a failed lysis. So 2/3 have a acceptable degree of ST resolution. 1/3 fail. Also, if you look at tenecteplase and alteplase, they have a weight-based dose in compared to streptokinase, where there's a fixed dose of 1.5 million units. So for a big person, it's a small dose, and for a small person, it's a big dose. And also streptokinase, the risk of bleeding is higher than a fibrin-specific agents like tenecteplase, reteplase, or alteplase. So if given a choice, prefer latest fibrin-specific newer fibrinolytic agents. So let's take this example. A 62-year-old male who complains of dyspnea for 3 days, pedal edema for 1 day. On examination, he has a pulse rate of 131 per minute, BPF 140/70. CVS thus shows an LVS3 and RS shows bilateral crepitations. Have a look at the ECG. Required, you can press the pause button. What will you do for this patient? A, you see the ST elevation is elevated, ST is elevated. Let us thrombolyze this patient. There may be some benefit. Or you take up the patient for PCI. So what do? The correct answer is you don't do anything because this patient is past your window period. Already 72 hours have elapsed. The patient is in heart failure. Whatever damage has already been sustained. You don't go create new damage. So you manage the patient's heart failure, give him dual antiplatelets, statin, heparin, ACE inhibitors, beta blockers, stabilize him, and then consider him for an angiogram later. Don't do anything right now. Don't take him for a PC or lyse the patient. Now, why is the ST still elevated? It's probably due to the presence of a dyskinetic segment or a segment which does not coordinate with does not cause myocardial contraction properly. So that is one reason. Two is the ST might have been further elevated and it's probably coming down. That could also be an explanation. This is a very important point. Relationship of mortality reduction and extent of myocardial salvage as a function of total ischemic time. If you look at the CCG, look at this graph, you can see that maximal myocardial salvage is obtained in the first 4 hours. After 4 hours, there's not much of myocardial salvage. So whether you do primary PCA or thrombolysis, you try to do it as early as possible within 4 hours to get maximum myocardial salvage and mortality reduction. In fact, you have trials saying that within 2 hours, both PCA and fibrinolysis almost have equal outcomes. So try to do your procedures within the first 4 hours. There's also another question here is some people, especially I've seen some senior doctors say that you would prefer streptokinase. The reason is they say is that streptokinase is a longer lytic effect, it lasts for 24 hours. So continuous lysis even after the duration of the newer fibrinolytics, which lasts for around 3 to 4 hours. However, although this is true, this is not preferred because there is no point in lysing the thrombus after the myocardium is dead. So after 12 hours, probably a myocardium is dead. So having a systemic lytic state after 12 hours, there's no use. It's only going to increase the risk of bleed. So you want quick action to happen within a narrow frame like newer thrombolytic agents. Third point is early T wave inversion as a marker for reperfusion. So you can see that MI usually has a definite evolutionary pattern with hyperacute T waves, ST elevation, formation of Q wave, subsequently Q, ST elevation and T inversion. Finally, the ST comes down and lastly the T becomes upright. Non-reperfused MI T wave inversions occur within 4 to 24 hours. These are called post-ischemic T waves. They're not seen within 4 hours. Rapid T inversions within 4 hours are robust indicators of successful reperfusion and correlate with decreased mortality and increased TF. So you lyse the patient and promptly you have T inversions, or you take a primary PCA and immediately after the PCA you see all the T's have inverted. This indicates that you have achieved reperfusion. And this correlates with early peaking of cardiac enzymes. Suppose you have done a CPKMB at 0 hours, 6 hours, 12 hours, and 18 hours and 24 hours. You can see that the maximum peak of enzymes will be around 6 to 10 hours in case of a reperfused MI. In case of non-reperfused MI, it tends to be between 18 to 24 hours. So early peaking of cardiac enzymes and rapid T inversions less than 4 hours are also indicators of reperfusion. This came in JACC in 1994. This is Journal of American College of Cardiology. Early T wave inversion after thrombolytic therapy predicts better coronary reperfusion. Next is you have lyse the patient and post lysis you see this ECG. What do? Do you give a DC shock? Do you give amiodarone? Do you take the patient for rescue PCI or do you relax? This is a case of accelerated idioventricular rhythm, AIVR. So idioventricular rhythm has a rate of 40. Accelerated idioventricular rhythm has a rate of around 40 to 100. So this is a marker for successful reperfusion, both post-primary as well as post-lysis. Do not do anything. Do not shock these patients. Do not give amiodarone. Do not take up the patient for rescue PCI. This is actually a marker for successful thrombolysis, and this requires no further management for AIVR. Okay, you should pat yourself on the back, congratulate yourself. Your patient is doing well now. I have seen many cases which have been shocked and or given amiodarone or lignocaine, saying that the rhythm won't revert. They diagnose this as a VT. Indeed, actually AIVR looks like a slow VT, but in this context, don't do anything. Reperfused arrhythmias like AIVR as a marker of reperfuse. It has poor sensitivity, around 45%. However, the specificity and positive predictive value are nearly around 95%. In occurrence of AIVR, recanalization of infarction related to coronary artery is very probable because it has a high specificity and positive predictive rate. But if you don't get AIVR, you cannot say that the myocardium is not reperfused. So if you get it, it definitely indicates reperfusion. If you don't get it, you cannot say that the patient is not reperfused. Sinus bradycardia associated with hypotension. Suppose just let's imagine you're lysing a patient with streptokinase and you find that the patient goes in for bradycardia and hypotension. I've seen many people stop the lytic agent saying that this patient has gone for anaphylaxis due to streptokinase. However, this is not true. When the artery opens up, usually you get bradycardia with hypotension. This is basically due to increased vagal tone. While doing a primary angioplasty, when you pass a wire and balloon dilate, the BP drops and the patient goes in for bradycardia. You ask the patient to cough or give atropine. This is a marker for reperfusion. So when you are lysing with streptokinase, when you see this, do not stop the streptokinase. You can give IV fluids or atropine. This is actually a good sign, does not indicate anaphylaxis. Look for other anaphylactic signs rather than sinus bradycardia with hypotension. Late diastolic VPCs which are occur after the P wave has been inscribed, or a twofold increase in VPCs, which is ventricular ectopics, are also soft signs for reperfusion. Disappearance of AF. Suppose you have an MI with AF and the AF reverts, you can probably say it as reperfused. Let's say you have an anterior wall MI with a right bundle branch, which indicates a proximal LAD occlusion. Post lysis, your right bundle branch block has resolved. This is also a soft sign for reperfusion. So sinus bradycardia associated with hypotension. Do not mistake it for anaphylaxis. Late diastolic VPCs or a twofold increase in VPCs. Disappearance of AF and bundle branch blocks. Now you lyse the patient. What next? Suppose a successful lysis, the patient has pain-free, you have a good ST resolution, you take him up for a pharmacoinvasive PCI, in which you do an angiogram 4 to 24 hours after the lytics and then see what's going on inside. Remember, when you do an MI usually has a lesion and a clot over that lesion in various combinations. You might have a 30% lesion with a 70% clot, or you might have a 50% lesion with a 50% clot, or a 90% lesion with a 10% clot. Lytics lyse the clot, they don't do anything to the lesion. So you need to see the residual lesion, as well as they assess the status of the other coronaries. For a failed lysis, you take up the patient immediately because the myocardium is right now ischemic, the artery is closed. You need to restore blood flow as soon as possible. What are the markers of reperfusion? The first three markers are your hardcore markers: prompt resolution of pain, achievement of electrical and hemodynamic stability in a person who was previously electrical or hemodynamically unstable, ST resolution of more than 70%. The last four are soft signs, like early T wave inversion less than 4 hours, early peaking of CPKMB levels, or a lower cardiac enzymes peak. Suppose the troponin levels will be lower because the MI has been aborted. Reperfusion arrhythmias like AIVR, late diastolic VPCs, frequent ventricular ectopics, bradycardia associated with hypotension. And lastly, disappearance of AF and bundle branch block. So keep in mind the markers of reperfusion. They will help you save a life ultimately. So if you like these videos, please like, share, subscribe, and press the bell icon to get notified when a new video uploads. Thank you.